So good evening, everybody. I'm Dr. Kalpesh Jani. I'm the president of AMASI, and since we took over with the new executive committee team in Hyderabad AMASICon last month, this is the first official program of AMASI, which is the AMASI CME. This program is being done every first Thursday of every month. This month, we are starting off with a bang. Hernia is, of course, one of the commonest surgery being performed worldwide, also in India, especially minimally invasive hernia surgery. And there's a lot of excitement in hernia surgery nowadays because of newer procedures that have come up. For a long time, and even now, but the most commonly done laparoscopic hernia procedure, minimally invasive hernia procedure, is the IPOM or the IPOM plus procedure. But then we have new challenges, and more and more people are, shifting to extraperitoneal approaches, including the ETEP-RS, the ROM/TAM, or the TAPP, completely preperitoneal hernia repairs. And the enthusiastic supporters of this extraperitoneal, or rather the over-enthusiastic supporters, I would say, Jan would probably agree with me, that would say that this has now, sounded the death knell for the IPOM repair. To know the current status, whether that is true or not, and what is actually the way forward, and what the future holds for us, and what is the current status from IPOM plus, we have today one of the most well-known names in herniaverse, Dr. Jan Kukleta from Switzerland. And to introduce him, I'll just hand over to Dr. Rajdeep Singh, who is the program convener, director of our AMASI CME program. Rajdeep, over to you.
Thank you very much, Dr. Jani. And ladies and gentlemen, it is my proud privilege to introduce Dr. Jan Kukleta, who is a leading proponent of minimally invasive hernia management for the past 3 decades. He's also the president of the Swiss Working Group in Hernia Surgery. He has been a member of working groups for the EHS guidelines for treatment of groin hernias, what we follow and we quote everywhere. The guidelines for endoscopic hernia treatment of the International Endoscopic Hernia Society, the guidelines for laparoscopic treatment of ventral and incisional abdominal wall hernias, the EAES Consensus Development Conference on Endoscopic Repair of Groin Hernias, and is also part of the Hernia Search Group, which developed the common world guidelines. So whatever you think of, he's traveled all over the world. He's known everywhere. Of course, he is considered to be the one who originated and propagated the concept of IPOM plus. He's got more than 70 publications in hernias. And yes, he is a friend of India. We often see him here in conferences. Thank you very much, Dr. Kukleta, for joining us. Dr. Rajesh.
Where is Rajesh? Disappeared. His video is not on.
Oh, yep. I think he's
not here.
He's got logged out.
Yes, I'm here. I'm here.
Oh, yes, yes. Okay. So you have to just introduce the faculty.
Yeah, well, the first of all, good evening, India. Whoever listens to us. Good evening.
Good evening.
Hernia friends. I think, first of all, I would like to thank Rajesh Srivastava for your impressive introduction of my insignificance. It's sometimes when I listen to this, that all that is about me, I just don't feel competent enough. And it stresses me. But on the other side, I would like to thank you for the chance to appear with some giants of Indian hernia surgery on the same screen at the same time. This is exciting. Well, I was always kind of one-man band, kind of messenger. So let me start with a little message. Well, if I can share my screen and put up my presentation.
Dr. Kukleta, before you start your presentation, let us have Rajesh. Can you introduce Dr. Pramod Shinde, who's the faculty?
Yeah,
of course. Okay.
So today we have 3 learned faculties. The first one is, Dr. Palnevelu sir, who will be joining very soon, and there is no better day to introduce a person who is teacher of the whole country as well as the world. So he is Dr. Palnevelu, and I don't think we need to introduce him. I will be very small to introduce him, but just to say a few words that he is the twice BC Roy National Awardees. He has many lifetime achievement awards, and he have invented so many techniques in which the cancer esophagus in esophagectomy is one of that, laparoscopic Whipple's operation is one of that, hiatal cyst is one of that, and single incision colorectal cancer resection is one of that. So after this, our second faculty is Dr. Pramod Shinde. He at present is the president of prestigious AWR Community of India. He is the director of Kaushalya Hospital and Research Center, Nasik, and he is practicing since 1987. You cannot see and tell his age just by looking him. He is so young and smart. He has many publications and many awards in his name. If I start reading, it will be too long. So I will just introduce Dr. Shinde in front of you as a faculty today. And the third one is very dear friend, Dr. P. Senthilnathan. He is divisional head, Department of Hepatopancreatic Biliary Liver Transplant and Minimal Access Surgery, GEM Hospital, Chennai. Again, he has a very long list of awards like Dr. Ashirvada Nohar Memorial Gold Medal, Young Investigator Award, Gold Medal in DNB Surgical Gastroenterology. He is the first surgeon to perform webcast of lap Whipple surgery in April 2014, way back. He has many best paper awards, many best poster awards, and he has authored many chapters in hepatobiliary and laparoscopic surgery. So here I present Dr. Senthilnathan sir. These three are faculty for today's talk. And now over to Kukleta sir for his talk.
Thank you, Rajesh.
Okay. So let me get my... Can you see it, the presentation?
Yeah.
Wait a moment, put it full size.
Yeah, we can see the presentation very well.
Okay, yeah, I just want to put it full size. Okay.
Yes, it's fine.
Well, as I said, well, I was in the last 40 years a kind of messenger trying to put things together that the most people would not think about it. I like to read about new things and I'm participating in the progress slowly since 50 years of surgery this year. So let me start with a short message. I can imagine that you've heard about this 17 years old Indian girl that won bronze medal at the Paralympic Games in Paris. She won bronze medal in archery.
Yes.
She has no arms. I was so excited about that when I saw that. So allow me, if I come up with this, working hard, we can achieve much more than we think. This is what I would like to start with. Well, these are my disclosures, have no conflicts of interest. Well, concept of this talk is about IPOM. It was developed to improve the results of open reach stopper, especially because of infectious problems. IPOM Plus should reduce the deficits of IPOM. The extraperitonealization led to something that I call anti-IPOM argumentation. We will touch it several times today. And the rebirth of IPOM goes back to the gentleman called Lars Jørgensen, who presented that in Deep Impact last year in Delhi. It's a kind of rehabilitation of a dead declared technique for selected group of patients through long-term follow-up and clinical experience. Again, eminence beats the evidence sometimes. Well, we all know that we have 4 different possibilities to put our meshes into the abdominal wall: in onlay position, in a retromuscular sublay, in a pre-peritoneal sublay. It's not only transabdominal, it could be completely extraperitoneal, like presented by Tess by Bing and Lee from China. And finally, the position intraperitoneal, IPOM plus, Lira or Larder. Well, what's the problem? IPOM is a bridging repair. That means the mesh has got contact with the abdominal wall only in the parts of the overlap of the defect. IPOM Plus is an augmentation repair that divides the forces, first increases the contact between the mesh and the abdominal wall and decreases the shear forces that try to separate it. Well, I wrote it in the chapter in the guidelines of the International Endohernia Society that the breached area in IPOM is formed by mesh only, not having a muscular aponeurotic coverage, and as such is functionally adynamic. And that creates the well-known phenomenon of bulging and leaves space for seroma formation. And, as we will hear a little later, for the central ruptures of prosthetic meshes. Well, the overlap plus is in the classic IPOM, we decided the overlap between 3 to 5 centimeters as a standard. In augmentation repair, there's place for a bonus that you gain by closing the defect with the same size of the mesh. The transfascial external suturing increases theoretically the risk of infection. The defect sutures should be non-absorbable and transfascial sutures should be absorbable. Well, these slides are about 15 years old. Comparing bridging versus augmentation repair. By closing the defect to 0, the same size of mesh creates bigger overlap and makes the repair more stable. Well, 15 or 20 years back when we were doing this, we just did not have the skills. So we started with the external transfascial suturing and subcutaneous tying of the sutures. Later, we realized that we should have closed actually every defect, although not every defect can be easily closed, depending on the history of the hernia, the size of the hernia, the compliance of the abdominal wall, etc. And again, we used internal suturing with extracorporeal tying because we had to learn how to do that even without extracorporeal action. Well, what's happening now? This graph comes from HerniaMed, which is today's world's largest hernia registry, based on German-speaking countries, Germany, Austria, and Switzerland. And you see the last 10 years, the IPOM, the red curve, is decreasing from 34 to 22% to 21%. The new kids, ETED, is around 10%, not enough. And what increased? The old open reef stopper to 42%. What's a shame that in the last 10 years, still the open suture figures here with 10%, although everybody knows that suture repair for incisional hernia repair is absolutely not the suitable technique. Well, is there a correction due necessary? The reason for extraperitonealization of meshes are known and logical. As I called it, anti-IPOM attitude, it's in very many cases absolutely correct, and few it's not. The implementation is much tougher than expected, technically not for everyone, sometimes an overkill for hernias of 2 or 3 centimeters to give them an ETAP of 20 by 25 centimeters mesh. The pendulum is coming back, but not in the desired direction. Well, to explain myself, I had the honor to write these 2 chapters of a Art of Hernia Surgery of Giampiero Campanelli. And I wrote the preface myself. I am aware of the fact, or even convinced, that the days of these modern techniques are already counted. Well, defending IPOM Plus sounds like 2 hearts beating in my chest. I will explain you why. Well, I created that acronym MINIM repairs, minimally invasive non-intraperitoneal mesh repairs, in contrast to IPOM or IPOM Plus, less pain, limited need for fixation, low material cost, lower risk of mesh-related complications, and lower risk of enterotomy. Well, it was me who actually created the session at the European Hernia Congress, so-called future-oriented session. And I had the right to invite my guests. I invited Victor Rado, Jorge Dias, and Antonio Bellido Luque, 3 surgeons that by then nobody knew in Europe. And then the young guy says, goodbye, IPOM. And since then, he's perseverating on that. Well, we are very good friends, actually, both Victor and I, and Jorge Dias. But, you know, the challenges of ETAP for ventral hernia, Jorge put it in press. Many surgeons are unfamiliar with the space. It requires formal training. Accidental pneumoperitoneum or previous abdominal wall surgery may compromise the technique. And the complications like intraparietal hernias, rupture of the posterior rectus sheath, injury to linea alba, disruption of semilunar line, injury to neurovascular bundles are becoming more and more frequent. Well, it means it creates more challenges. I think, Pramod, this picture is from you. You published last week, just several days ago on in International Hernia Collaboration.
True.
That's unilateral injury to semilunar line. This is Yuri Novitsky's bilateral injury. Another one, bilateral injury and rupture of the posterior rectus sheath. Well, and these injuries or these mistakes or developments are just terrible because they are very difficult to be repaired at all. Well, on the other side, the little plus, I smuggled it into the guidelines just for fun because I didn't know, should I write plus like mathematics or should I write plus? But nobody noticed it actually. So I thought they could kick me out with this denomination, but they didn't. And I'm absolutely sure this guy had 2 cancers and his life expectancy was very limited. He was happy to come out after, this is about 4 weeks after the surgery. And it did him very well. Well, the plus is in IPOM closing the defect. Well, the group of Yuri Novitsky presented a paper demonstrating the difference between closing and not closing. Significantly less SSOs, significantly less seromas, significantly less recurrences. So actually closing the defect, for me, there is no more discussion about it. Close as long as it is possible to close it. Need for penetrating fixation is the next problem of this technique. Well, this X-ray is a patient of mine. He had 2 different, he had a medial hernia and a lateral hernia. And I just put the original text, would you like to look like this after your successful repair? In parentheses, especially when you have abdominal wall pain and you don't know which tag should be removed. Well, when I saw it once in India, this picture, so I thought, yeah, finally made it around the world. The message came through because this cannot be the way. Well, the same transfascial sutures. It seems obvious, easy to find place where there are no vessels and believe in it until it still bleeds. Well, we all hate pictures like this. I know they are rare, but still for the person that has the problem, it is a catastrophe. Okay, so what about the literature? What do they say? Well, this paper is very special. It's a systematic review of 11 studies that comes to the conclusion that the extraperitoneal mesh does not appear to be superior to the intraperitoneal mesh. Well, I have a little bit of problem with this because this is probably a selection bias on these 11 studies, because there is a quite clear difference. Well, sorry that Palanivel was not here. One of his kitchen, ETAP compared to IPOM Plus. And again, ETAP is comparable to IPOM Plus in terms of postoperative pain, analgesic requirements, cost of mesh. I don't believe that it is true. And the length of the hospital stay. Yeah, that might be true. How come? I knew that because when I read the first page of the paper, I knew what comes on the next paper, on the next page. This. In Coimbatore, he told me they don't have tackers in the hospital. They use single sutures. And that makes possible that the VAS scores are so similar after 7 days. Well, if you look for contradiction, you will always find some. But this one concurs. Robotic ETAP versus robotic IPOM. Again, the avoidance of fixation in robotic ETAP repair did not reveal a benefit in postoperative pain. How come? Well, the VAS scores are practically identical. Yeah, if you read between the lines, the mesh in robotic IPOM Plus was fixed with running suture and not with tacks. Well, if you want to have a contradiction, you will always find some. This is about selection bias. You know, this paper is from Turkey. Halil Taskel presents what is to be expected, comparing ETAP and IPOM Plus. Less postoperative pain, shorter lengths of stay, but operative time 2.5 hours longer for ETAP than for IPOM. And these 2.5 hours, that is in Switzerland, operative time costs about 30 francs a minute. So that would be about 1,800 francs more expensive. And he compares transfascial sutures and Absorbatak to no fixation in ETAP. So we have to differentiate it. There is a similar paper, robotic retrorectors versus LAP IPOM Plus from Denmark. Again, less postoperative pain, shorter lengths of stay, comparing auto-fixating mesh ProGrip versus capture. And of course, that patients that had capture fixation needed a tap block significantly more often than the other group that was not injured. So the moral of the story is actually the penetrating fixation requires better analgesia. And this is not a witchcraft, you know, especially when another paper that comes from the neighborhood of Palanivel is that paper about surgeons making his tap block himself, because who is more motivated than the operating surgeon himself? I didn't know that it was called Doyle's internal bulge, but I've learned something. This paper was published this year. The group that had tap block was, of course, did not need additional analgesics compared to the other group, the difference between 14% and 72%. You don't need much mathematics for that. Well, Ferdinand Köckerling is the spiritual father of hernia med. As I said, the today largest hernia registry of the German-speaking countries and the English-speaking countries. Well, the current evidence shows a significantly better outcomes for IPOM compared to open procedures. He cites a paper from Denmark, Kokotovic from 2016, mesh-related complications in open. Reached OPA 5.6%, LAP IPOM 3.7%. So his conclusion, Ferdinand Köckerling's conclusion, is that concerns of several experts decreased IPOM repairs and increased open sublay repairs, despite the fact that it is the biggest registry. They represent in Germany only 25 to 28% of all surgeons. So it is not, generally speaking, what happens when you remember the graph that I showed you at the beginning. Well, there's another paper trying to explain another factor. This comes from Michael Rosen group. I will help you with this text here. IPOM placement created negative attention due to long-term risk of mesh-related complications, but the data are sparse. And their result is the rate of reoperation due to intraperitoneal mesh complications was 0.62%, 2 out of 325, with a follow-up up to 6 years. So again, is that so relevant as an argument to stop using IPOM Plus as a good technique to repair incisional abdominal wall hernias? Well, why is IPOM still so popular? It is relatively easy to perform, allows placement of larger mesh, it's faster, may detect occult hernias, has very low infection rate and shorter hospital stay than the open mesh repairs. Well, what would be a substantial improvement of IPOM Plus? Definitely refining the procedure, clearance of the preperitoneal fat, correct mesh defect area ratio, MDAR, because in bigger hernias, the overlap is not enough by 5 centimeters, but maybe 8 or even 10. Transfascial sutures should diminish shrinkage, depending on the material that you use. And we need better understanding of the dynamic biophysics, like Friedrich Kalinowski reported in India about his dynamic intermittent strain and gain resistance to impact related to pressure. These coefficients are different for different meshes. And an important fact that comes probably a little later. Well, so I stop it here, but what we can do, improve the quality of IPOM, refine the technique, is to improve the safety. If you use Veress needle for your pneumo, you should look what happened with the Veress needle before you take it off. You should control the first trocar, because even if it was optical trocar, it still could pass through a bowel loop. So looking back does not cost much, increases safety for the patient. Well, preparing the landing zone, when I see the IPOMs in very many other countries, I see that people don't bother with this. They just take it to the wall and go, and don't wonder that this does not hold if there is no direct contact to a solid abdominal wall. Well, in the beginning of IPOM, we put the transfascial sutures in this position. Today we call it diamond position. Then we realized that under each one is the epigastric vessels, possibly. So we turned it 90 degrees around and diminished actually the potential of risk to vessels and nerves. My plea for the mesh trimming, the margins, the corners, don't add any stability to the repair, but increase the number of tacks that you need. So even with double crown, you use less tacks than if you don't trim your mesh. Well, what would be another substantial improvement of IPOM Plus? Better mesh properties, of course, this is what we wait for. More effective visceral interface and porosity, but effective porosity, that means in vivo porosity and not in vitro, to prevent adhesions, prevent late mesh-related complications. Yeah, this is what I wanted to talk about the anisotropy of the abdominal wall. The abdominal wall has got different stretchability in different areas. It's not only lengthwise and transverse-wise. And our meshes don't respect that. We need multidirectional stretchability to get closer to the isotropy of the abdominal wall. The abdominal wall has got factor 8 to 9, and our mesh is between 1 and 2.5, maybe 3. And this is not enough. So mismatch of these two stretchabilities can disrupt the mesh tissue interface even then after a solid ingrowth took place. Yeah, less painful mesh fixation. Well, after doing the plus first, solid closure of the defect, it's possible even in the meshes which are not permeable, like this Symbotex here, to put cyanoacrylate glue behind and bring it to the abdominal wall. It's a little bit tricky, but Paul Wilson published 138 cases with very good results. So using additionally cyanoacrylate glue between the gaps of hacking, probably a reasonable thing. Well, how much fixation is necessary? Well, single crown creates a lake of seroma. A double crown divides the lake into several swimming pools. Probably the multi-crown fixation would divide the swimming pools into many small puddles. And I think it's important because when you leave the film of fluid here for the next couple of weeks or even longer, how come that the ingrowth takes place? There is no ingrowth. That was actually the biggest mistake of Physiomesh then before it was withdrawn from the market. Well, mesh fixation relating chronic pain factors. The least people know how long are the devices that they are using. Hard fixation does not compensate for insufficient mesh size. Penetrating fixation is forbidden in certain areas like triangle of pain, hiatus, diaphragm, close to the lateral nerves. Well, absorbable tacks are not safer than the metallic ones. Shrinkage of fixed meshes causes intrinsic tension or tack hernias, as they were described by Philip Maisons 15 years back. Penetrating fixation endangers even the nerves on the opposite side of the abdominal wall. Why? Can you imagine it's a kind of injustice, selection bias again? Because these three are not correctly placed, and only the own proprietary was correctly placed, but the depth that it reaches is important. The difference between a tacker with it's incorrect, it's 3.9 millimeters, and the secure strap with 7.2 millimeters. We were just joking and saying that if you have lean patients, you can use one tack to fix two patients together. The length of the devices matters. Now, this is basics. What would be another substantial improvement of IPOM if we would finally had some evidence-based selection of patients? The update of the incisional hernia guidelines has the limit of 15 centimeters. The original was 10 to 12 centimeters, and this is both incorrect. We know that closing the defects the way we do, sometimes even 6 centimeters, can be painful. It all depends on the compliance of the abdominal wall. The definition of ideal indication and clearer definition of limits would do well. Well, when can IPOM Plus be a good indication? In obese, in elderly, in problematic soft tissue conditions, risk factors for healing problems, in risk factors for recurrence, like old age, females, immunosuppressants therapy, previous open mesh repairs, patients with multiple hernias, and actually only good for small to mid-sized ventral hernias. What about artificial intelligence? Everybody talks about. I did question ChatGPT just for fun. What about the rebirth of IPOM? Are there better techniques? Can you compare ETAP with IPOM Plus, etc., etc.? Can you make a PowerPoint presentation? Well, the system is quite eloquent. Says the rebirth of IPOM Plus suggests that the surgical community is re-evaluating and potentially improving upon established hernia technique. I don't know how they learn it or who taught the system this, but the system apologized that he is a language model, so he cannot create PowerPoint presentations. And he would provide me with some information and comparison between extraperitoneal endoscopic transversus abdominis release. He calls it ETAP technique and IPOM Plus. And I wrote him back, man, you are just producing fake news. So he apologized again. Welcome, Dr. Sentillan. Very happy to see you. Well, I would like to summarize. This is actually that Lars Jørgensen presented in New Delhi from the Danish hernia registry. The indication correct to be able to say that lap IPOM is more efficient is just for the mid-size hernias. The wound morbidity is less early readmissions, less early reoperations, and late mesh-related complications. Well, lap IPOM is still a valuable tool in surgeon toolbox. The experts say avoid implementing these new techniques in low volume centers without adequate preparation. This is probably the biggest problem, because otherwise we would not see that many ruptures or injuries to semilunar line. And the fears of intraperitoneal mesh may be exaggerated and should be compared with the complications associated with extraperitoneal hernia repair. So my conclusion, that's not printed anywhere. It's just my humble opinion. The advantages of ETEP approach seem to be obvious, but the systematic reviews and RCTs are still not conclusive. The pain related to fixation can be optimized by tap block. Mesh-related complications are rare, as presented, and the risk of intraperitoneal mesh requires better meshes or extraperitoneal mesh placement, especially for young people. So this is not against ETEP, but it's more difficult technique, requires better training, and without a mentor coming into something like ETEP, probably only Victor Radu did that because he learned it actually from YouTube himself. But we are not Victor Radu. So run, but run with caution. I thank you for your time. We're still thinking beyond IPOM. That's it.
Wonderful talk, Dr. Kukleta, and you have justified rebirth of IPOM Plus. We can very well say, Sidhe sir, over to you.
Well, thanks, Rajesh, and thanks, Jan, that you have covered the topic very well and actually reviewed the literature for us and put IPOM Plus in a very good perspective, citing both the positive aspects of it and the negative aspects of it, and also cautioning that the data may not be really sufficient to just take off IPOM Plus from our armamentarium. And probably the complications are not as high as we count it to be. I just had one question for you, or maybe kind of a comment also, that isn't IPOM Plus also a very good tool for young surgeons in training, because much less than what an ETEP ARIS would have. So we would want our residents to have some way to get into laparoscopic repair of ventral hernias. So do you think that IPOM Plus fits the bill and it is still going to be a very useful tool for training of young surgeons, especially in their residency days and when they pass out?
I think so, especially when we know that we select the patients for that. We've realized ourselves that the fat guys, they don't suffer from pain. It is, especially in them, it is much easier to decide to do IPOM because the techniques is faster. People who are in need of short operations, like, for example, the patient that I showed with the 2 different cancers that do short life in front of him. So, you know, he was happy. He maybe had pain for several days and that was it. And this is what we know. So I don't think that we should just sacrifice a good technique, because the biggest problem of everything is not the recurrence, but the infection. And returning back to open reef stopper, we don't know the numbers of infections of reef stopper. What we are talking about, the problems of chronic pain and mesh-related complications in young people. So definitely, I believe that IPOM Plus is not a very good solution for 28 years old lady with epigastric hernia. This is definitely not. And even if you should do it open, it's probably the better indication than just put tons of tacks in her. I don't know how you see that.
I agree about the tons of tax comment, So that is one of the bane of IPOM Plus. So like Dr. Palanivalu, the GEM group, which does a lot of suturing for IPOM Plus, they've also shown that
I've been there.
It's less. We'll still find it place in the armamentarium of these young surgeons and robotic surgeries.
I'm just teasing my colleagues in Europe because they would rather use 2 pair of tackers than to do all these single sutures. And this is about skills, especially when you have a limited number of trocars. When the Indian can do it, I think we should be able to do it too. Although maybe we don't have that skills. We don't have that high caseloads. But again, I've seen quite a few people, not only Palanivalu, he can do crazy things. I've seen several very talented people in India. So I just believe in it. And that's why I brought that message about the young archery girl that without arms,
True.
the bronze medal. Europe is just crazy about that. It's in all newspapers since 3 months. I don't know if it reached India as a story, because this is a fantastic story.
Yes.
Have you heard about this girl?
It has.
Yeah.
We are very proud about this kind of an achievement, and the whole world is charged up with it. Yeah.
I understand it because my wife is Brazilian and she follows the number of medals of the Paralympics now in Paris on behalf of the Brazilians. But so it's all right. It's about men's will or women's will. And this is just crazy. And this inspired me to bring it in. Don't know if it was correct, but I still believe that it's a fantastic thing to think about. So what about learn how to suture from every corner of the abdominal cavity? And using the tap poke.
Dr. Senthil is here. We want your comment as well.
Yes. Thank you, Rajesh. Professor Kukleta, it's always a pleasure watching you talk on any subject, and more so for laparoscopic IPOM. I still vividly remember you are sitting on the stage, on the floor during the hernia carnival. I have taken a picture of it, still vividly, just before COVID. And then we also had the second edition of the same hernia carnival earlier this year with the same zeal and enthusiasm. Of course, we missed you big time in person. Probably next edition we will be definitely having that is in 2025. 26. We'll be having the third edition of the carnival. 26. You should be coming back to Chennai. Having said,
I'm coming already 25. In March 25, I'll be there.
Yeah, it's 25 and hernia carnival for 26 as well. One comment as well as one question. The comment is, where do you foresee the place of, is it different tools for different hernias rather than having one nail to, a solution for all problems? That is my question. And my comment is, I think we should have the proper IPOM plus done in the proper way, not a double crown. And you also elucidate to that particular point of doing more intracorporeal sutures, reducing the cost, reducing the pain. So now can we compare the good IPOM versus ETEP? I think then the results should be out so that the so-called inferior results of IPOM can be avoided. That is my comment. And to add to that, we have been doing IPOMs for now more than 20 years. To be precise, we started in 2003. We have now crossed 20 years of IPOM. My comment is, if you do it in the proper way, it is also one of the armamentarium to especially in uncomplicated ventral hernias. Your take on this, Professor Kukleta?
Yeah, well, excuse me when I'm laughing, but it's more smiling because you missed that part when I talked about doing the IPOM properly. You know, resect the fatty street, prepare everything. Well, think about where you put your transfascial sutures, limit the injury to the abdominal wall, tying the transfascial sutures like an idiot, because of course it hurts, but it doesn't have to be so. So make it properly. Again, maybe it is a disadvantage because it looks so easy. So everybody just takes a mesh, maybe put the central suture in it and start stacking. And this is not the way how to repair it. And that was part of my presentation because you've been probably late or maybe you were watching me.
No,
and
I was watching you. I was watching you from the beginning. Yeah.
So, and the second is a big slogan, of course, tailored repair. The most of us have some predilections or favorite techniques that you do better than this. You know that I'm a tapist and that most people are tapists and for inguinal hernias. And I have my reasons for that. But again, when it is necessary, we need an armamentarium of different techniques to be able to suit the technique to the patient. And not only to his hernia, but to his needs. What quality does he need for the repair? Because we maximize everything. And for many people, it is certain overkill. So there still are quite a few techniques that we all should know to be able to tailor it. And this is probably what you meant, if I did understand you right. There is not one thing that fits all.
And the last question is, do you see any stigma associated with IPOM? I may provoke you by asking this, because now the young surgeons, the herniologists are moving towards a retromuscular repair and especially in laparoscopy. So do you see any stigma either now or in the immediate future for IPOM or IPOM plus?
Well, not really. As I said, the ETEP approach is for groin hernias much easier, but there are very many conditions where the ETEP is just for absolute experts. The first publication, I remember when Victor and Bala and Ramana and Bielyansky put their first papers, 7 authors, their average operating time was 210 minutes plus minus something. So 3 hours of surgery for something that you would do maybe in 50 minutes with another technique. But it's all about indication. And I think very often we have to ask the patient sometimes what he expects, what does he need? Is he sportive? Does it have to only prevent the recurrence? Epigastric hernias, there's still open surgery. There are still hernias that can be closed by transverse suture with non-absorbable material. Although I favor meshes since ever, but there are still mesh-free repairs on certain conditions, but definitely not for incisional hernias like the 10% in the German hernia med, because this is just negligence, nothing else. So I think it's still good that we discuss it. And I can tell you, maybe I will send you a mail tomorrow how many colleagues will complain about myself talking about rebirth of IPOM.
Sir, many residents are there in the audience. So few very basic questions. Number one, I learned from your talk, which is very important, that transfacial suture should be absorbable, right?
Yeah.
Number one, very great lesson, because most of the surgeons are using Prolene for that. But I think after you talk, we all should use PDS for that, right?
Yes.
Or Vicryl.
No, well, but it could be both, but I still believe I use PDS since ever we used the transfascial sutures, what we learned about it, that they should not be really too tight. They are so-called air knot sutures. It's just a security for something when you have a heavy cough of something that it just does not disrupt from the abdominal wall. And that's why I don't believe that the transfascial sutures are so dangerous. But when I see the American colleagues, how they tie it and how much force they tack, the most tackers are bent 90 degrees when they finish the operation. So this is not really gentle. You need your hand, not the assistant's hand that you fire against. So you know that you fire between your fingers and not into your fingers, but you can modulate the abdominal wall so that it is perpendicular. There are so many details about that. Well, whom am I telling you? You all know that, but tell it to the other guys.
The second question is, when should one tie a transfascial suture, after deflation or when there is pneumo?
Yeah, well, I have my strategy. I always decrease the pressure, not completely, because I need some space to see what's happening actually. But I mark it for myself. The nearest margin is called east. North, because I'm standing on the left side, south and west is there. You never start fixing the west, because then you dislocate the mesh very often and have an asymmetry in the fixation. So my first fixation is east. And with the rest, I just start tucking there where it fits when it is nearly deflated. Because this is the physiologic situation. And the abdominal pressure in a lean person could go down to 4, and you still can continue tacking. But in a fat guy, you still need 8 just to see something, because they are used to higher intra-abdominal pressure.
And the third question is, how many transfascial sutures?
Well, if it is just to facilitate the positioning, to guarantee that it is correctly positioned, that you have then a nice contact with the abdominal wall, so 4 would be enough, but it depends on the size of the mesh. If you have 20 by 30, maybe 6 would be advisable. You don't have to tie them all afterwards, but for the positioning, to get nice contact with the abdominal wall without waves in between, creating artificial lakes for seromas, and then I think, well, we did not discuss the central suture. The centering suture goes very often through the main defect. And this is the worst tissue, actually. So entrance for bacteria, I never used it. I just laughed about it. You know, English very often used this as the only transfascial suture. Put it in the center of the mesh. That will guarantee the symmetry of that. But once you start stacking at the east first and then in the west, because otherwise the mesh just goes on the other side.
Now the other question is regarding tackers. Which is ideal, absorbable or non-absorbable? And what is the difference?
Well, I said that, you know, when you hit the nerve, it doesn't help when it is absorbable. Second, the absorbability takes much longer than it is indexed. We saw the first absorbable tags after 2 years, although they should not be there. And then, so I would not rely on absorbability. It's sometimes even, yeah, well, especially in groin, I just, for me, it is absolutely useless to use tacking, because I use glue since 23 years. But in incisional hernias, I still believe that we cannot omit completely the tacking unless you develop the skills like we saw the paper from the group of Palanivel. I always talk about him, although there was another first author, but God forgive me, you know what I mean. I think we should force the young surgeons. That was the question, Kalpesh. You know, we should force them into suturing. Give them the time, because today the surgeries don't have to be done so fast as it was 25 years ago. The anesthesiology improved too in the meantime. So it's not the question of operating time. So being 7 minutes or 12 minutes faster is just a nonsense. This is no discussion. Opinion of an old man.
Very true. The suturing also will help young surgeons and residents actually refine their suturing skills. So IPOM Plus could be a great tool for learning and refining your own skills also.
Absolutely. I declared it actually as a condition. Sometimes I'm very apodictic. I said, well, somebody who cannot do properly a suture should not be allowed to enter the abdomen. Because you have a serosal tear and start with some clips on a running suture because you don't know how to knot, and this is not allowed. I mean, it's like a driving license. And our driving license starts somewhere there. And actually it starts before the surgery. I always said it starts with a pneumo, but I wanted to just speak out how dangerous the pneumoperitoneum can be, especially with the optical trocars. I have a selection of nonsenses because I have to talk about it in Romania. It's unbelievable. People just go in one shot with a trocar directly into vena cava. It's just, yeah. But again, we have to start somewhere. And I think the suturing skills, how we were learning 50 years back, knotting at home, 50 knots in 1 minute. So this is basics. I hope that I don't, how do you say that? Well, it's not boring, but
agreed.
We have a special profession, requires little more than just talking. It needs the real skills, and I don't believe that the AI will suture for us in the next 10 years.
Very true.
And one more question is, first we should tie the transfacial sutures, or we should tack first and then tie the transfacial sutures?
No, for me, as I tie them very loosely, so it does not make much difference. I just want to guarantee that I don't cause any displacement, because this is what we were doing in the beginning until we noticed that Jesus Christ, that the mesh moved 2 to 3 centimeters to the opposite side, which was so much easier to tack. So our first technique was actually using 5 trocars on the opposite side, and to improve the solidity of tacking, because tacking just above your head when you have a bigger mesh than just 15 in the width. So you are always very close to this. So the quality of fixation on the eastern side is much less than on the western side, because you stand on the opposite. And I think that the Reliatech, that's the Medtronic product, that you can bend the front part, but it's not strong enough to guarantee that. So I still believe that you can use a stiff tacking device, but you have to use your hand to put it in the correct position so it enters into the tissue perpendicularly.
I can see Dr. Dilip Gode, sir, an expert laparoscopic surgeon from Amasi. Sir, your comments, please. Sir, you unmute, sir.
I still feel that IPOM Plus is good, and I do not do. I have not started doing E-tape.
Valanivelu, good evening.
Good evening, sir. So,
Great to see you.
Hello.
I am very comfortable with doing IPOM Plus.
I'm sorry, today you had a very important function here. I could not attend.
Yeah, well, we spoke about it. I presented the paper that demonstrated the 32 single sutures from every corner instead of tacks. Because when I visited you in Coimbatore, you told me we don't have any tacks. We don't use tacks. And this is how I tease my colleagues in Europe. I say, go to Coimbatore to learn how to suture.
Rajesh, maybe we can ask him any preference for mesh. Are all the dual meshes same, or with so many newer meshes coming in, the titanium mesh, the physics ST? So maybe we can ask him if he's got any particular views on the various types of dual meshes, barrier meshes that they have.
Yeah, Dr. Kukleta.
Well, we omitted the use of EPTFE meshes. And that, I would say 25 years ago, there is no ingrowth. How should it be stabilized? With heavy fixation forever. And that's our second problem, of course. So I would not use EPTFE mesh. It shrinks more than most other meshes. It's suitable, harbors infections. When it comes to infection, you have to remove it. Don't try to survive a EPTFE mesh. So dual mesh is, for me, not a solution. The combination of dual mesh or EPTFE with polypropylene has got a problem because the shrinkage rate of both materials is not the same, and that causes the so-called potato chip deformity. You know, they have to distort, and so for me, EPTFE does not exist as a mesh. Second aspect, tie mesh is not a composite mesh. Köckerling put it into composite mesh group, but it's not a composite mesh. And until several years back, it was not porous enough. The pores of tie mesh were lower than 1 millimeter, and we say it should be at least 1.5 or 2.5. So in the combination today, I think that the Versalite ST is probably the best product. Solid enough, and Symbotex seems to create central ruptures over the time. It's not strong enough. And the reason for that is because it's made out of monofilament polyester. And the previous polyester was multifilament, which was much stronger mesh. So I cannot say it like that. I'm not against Symbotex, but think about it. When you close a defect with a certain tension and then put Symbotex on it, it will end up with a central rupture. It was published several times now. That's a new entity, but it's a new product when it comes to that. The structure of the polyester is different. And in the past, we had the problems. Well, there is a paper by Leber from 1997 that he wanted to forbid polyester use in US because it caused many more infections in incisional hernia repairs than any other meshes. But it did not happen. Sometimes I have the feeling that some people who use polyester meshes just want to be different than the rest. So it makes it funnier, but I don't believe that it's necessary. We have good polypropylene meshes.
Palnivelu sir, are you there?
I'll just connect Dr. Rajesh. He is here. He was in a book release function at Hyderabad. His autobiography in Telugu is being released. So he's here. I'll just try to connect in the meantime if you can have some discussions.
No, well, but you can tell us your opinion, Sentilatan. What is your favorite mesh?
My favorite intraperitoneal mesh is Paritex. It's a combination of Paritex by the Medtronics Covidian.
Yeah, well, Paritex is still a multifilament structure, being composite. And Symbotex, which should actually replace Paritex. But I don't think that it will replace on the long run. Paritex, still very good mesh. You know, I asked the company to coat with the same protective measure polypropylene meshes, because they started actually with para-attacks, and they promised me in 2 years they will come up with polypropylene, and they have polyethylene, because you could not sell polyester in Germany before.
Oh, okay.
Because of the complications of the past, so the company promised me then that they will create the new mesh called polyethylene composite, which is very good mesh too. But you're probably right that you didn't hop on Symbiotics.
Yeah,
in India, sir. Yeah.
we stuck to Paratex. I still remember it was Sofradim, a French company.
Yes.
Then it was Covidian, then Medtronics. By 20 years.
You know how cheap Medtronic bought Sofradim? Only 25 million.
Oh, okay.
This is the basis of all their meshes up till today.
Okay.
Sir, in India, we have a company.
And the program comes from Sofradim, because otherwise Philip Shastam would never keep his patent if it was under Medtronic or US Surgical or you name them, Covidian. They all the time change the names. But
sir, in India, there is a company, Merrill.
Historic material.
Yeah. Hello. Yeah. In India, we have a company, Merrill. Merinium is their composite mesh, and I'm using since last 7-8 years, and it is again an equally good mesh.
Rajesh, can I ask a question?
Yeah, please, sir. Please, of course.
Yeah, Jan. So this question, as Rajesh very rightly mentioned, that there are a lot of precedents here. One very interesting thing happened in one of the groups where somebody raised a question that if you're doing an IPOM for an umbilical hernia, up to what size defect will you suture? And a poll was raised, and even a lot of senior faculty, there was no concurrence. I mean, the answers varied from 1 centimeter to 2.5 centimeters. Somebody they are saying so. What is your view on this? What size defect will you suture, and what is the smallest size that you leave it open and just put a mesh over there?
Okay, it's not only about centimeters. It's again, if you take a BMI 50, a centimeter is a different size than if you take a BMI 18 and a centimeter. That's the first. The second is I have to make the update on the small hernias for the German Society. So I've been collecting everything that was published about it. And people don't agree. Well, in Denmark, they made a survey about all surgeons who classify to be experts in abdominal wall repair. The agreement on the basics is 20%. The agreement rate among 5 experts. Right. And it's actually, that just demonstrates, well, the Dutch took the cutoff 4 centimeters. They say 2 to 4 centimeters are small hernias. The Danish say 0 to 1.5 centimeters and try to convince us that we should put meshes into hernias that are as small as 1 centimeter. You first have to increase the size of the defect to be able to put any mesh in it first. So you destroy more than you repair. And again, when we had the patches that were designed for the intraperitoneal use, we stopped very early with it because we always took 5mm scope just to guarantee that they sit well. Half of them was not okay. And then we saw some of the publications, what happens with them when they start distorting, creating true complications, small bowel obstructions, and then pain. And the Danish have a problem with formal teaching because this is the most crazy operation, the umbilical hernia, because they have the highest number of readmissions. They have very few centers that operate on hernias, and the people come from far distance. So when they are afraid of something, they have readmission, they have reoperations. It's difficult to understand how you can have so many reoperations on small umbilical hernias. So in my eyes, 1.5 centimeters or under, let's say, lean person up to 2 centimeters, I would suture if it was in childbearing age. Because when recurrence is not that bad, actually. Infection is bad, but recurrence or chronic pain is probably the worst complication that you can have together. So you can repair it, again, in childbearing age. People who really want to do their athletics just a week after, I had a 3 hours operation 3 years back. Da Vinci, repairing recurrent hernias in the groin, recurrent hernias periumbilically. I worked on the day 3, but I didn't play football. I didn't try to jump around because although I have the best meshes ever, I have a visible mesh in my groin, and so I can take a look back if it is still in the right position. But I think about clinics. We cannot do science about that. So it is difficult to compare. But again, the judgment does not come from nowhere. It's not measure, I have an index 1.5 centimeters, I have to put mesh in it. Well, think about the patient. What's the age of the patient? What's the condition of the patient? So I think around up to 2 centimeters, you still could justify a suture repair. Behind or beyond that, I would go for open retromuscular or preperitoneal repair.
Great. One other thing was that in one of the slides, I think you mentioned it, I think which Rajesh is very pointedly ignoring. You are a little pessimistic about the future of the extraperitoneal repairs. You mentioned that MIS extraperitoneal repairs may not last long in the future. Did I understand that correctly? That slide?
No, I think maybe I said it in a way that you understand it that way. No, I don't. But it has its limits. I was with Victor Rado together in Italy this year, and he's been just doing crazy things. 2 meshes, one intraperitoneal, the other one retromuscular, and he went ETAP, took everything out and put another mesh retromuscular. Not everybody should try that. Maybe take a look at the video, but don't try it on your patients. But so again, if you just master, well, I did every groin recurrence after laparoendoscopic surgery, I would go with retap. I know this is not guidelines conform. Well, I would explain it to the patient. I can handle it better. The risk of chronic pain is for me bigger than if I do a retap. I know that is more complicated. I know there is a potential of injury, but I know that. So I have to anticipate it. So, and there are techniques how to get over that. You don't have to explant all the meshes. So if you just go along the epigastrics, make a vertical cut, so you can manipulate the stiff material. This is not dangerous. Well, if you just don't mess around big vessels, you have to know where they are. And this is in the abdominal wall surgery very similar. So of course, what I see what absolute disaster is the injury to neurovascular bundles. And since I saw the presentation of Jake Gandhi, it was not him the first author, but he went out and put it on the internet just using cyanide green. You can visualize them. But it doesn't cost much. It doesn't cost much. Cost $1.50, so just injection. And so if you do surgeries like that, they are not just straight on. So visualize the bundles. Because when your rectines are completely gone, how do you repair the abdominal wall?
Yep.
And this is what we see, people bulge because there is no muscle anymore. Died after 9 months.
I was the co-author in that study, sir, ICG in ventral hernia. But my question is, you have shown a slide which was in between, I think, 16 to 19, which the latest, it was published last year, where IPOM is decreasing and ETAP is increasing. So why you think that this is happening if IPOM is so promising?
It was this group, Hernia Med,
right,
is 25% of all German surgeons. And Germany has got 80 million population. So it's many surgeons that are not in this statistic. And these people who are in this statistic are all hernia enthusiasts. They sent their data in. You know, so again, it's not a clear mirror of that what's happening out there. So it would be wise to teach correct IPOM before they start doing faulty ETAPs.
And I think that data was till 2018. And after that, in India, we have seen the surge of ETAP. Before that, nobody was doing.
Yes, and then again, you know, the data that we have in Hernia Med is just 1 year follow-up. So talking about recurrence rate is just cheating. I mean, not all the recurrences happen 3 months after surgery because these are absolute clear technical defects or faulty operations. But the recurrences, my recurrence came 40 years after my first operation, you know, so these are not true recurrences again, but something in between. It's difficult when we follow the data 5 years follow-up, they look completely different. And I have a talk in Singapore next month about unilateral or bilateral groin hernia repair. I am opponent of bilaterality there where there is no hernia. Why? Because there is a paper from Mark Miseres, follow-up over 25 years. Only 25% develop metachronous hernia. So the other 75 would get an operation that they definitely don't need because they would never develop a metachronous hernia. So this is our discussions. Somebody has to stand up and name it. It's so easy to operate bilaterally. I know that the group from Pradeep would rather go and say, explain us that it is collagen disease and that you have to make both. But I found papers that how many recur after they've been explored on the healthy side and not put mesh. That's below 10% after 10 years. So why should you, other 90%, get mesh for nothing? So I think this is the level of the discussion. We have to see the limitation of data that we are discussing.
True.
I think Rajesh, can we move to Roshan now to upcoming program?
Yes,
try to wind it in.
Yes, sir. Yes, sir.
Thank you, John. Yeah. Continuing with the robust academic and training programs of MRC, this year also we have lined up some programs. So go to the next slide. Yeah, we have a Safe Lab Coli program coming up at Joka, Kolkata on 28th September. And it's going to be a wonderful program, expecting more than 200 delegates to register. After that, we have, next is, next slide, please.
Yeah.
Yeah, 107th MRC skill course, which will be held at Lucknow. Dr. Anand Prakash and Dr. Nikhil are organizing this program between 4th and 6th October. So request surgeons who are interested in taking up FMAS exams to kindly register as soon as possible. It will be a very interesting program. Next slide, please. Prabhu, next slide. Yeah, we also have a Safe Lab Coli program coming up at Pune under the leadership of Captain Amit Kumar. It will be on 5th October at the Command Hospital, Pune. Next slide, please. We also have a MMAS program on HPB. It's a Mastering Minimal Access Surgery, the first advanced course in hepatopancreatic biliary surgery. It's between 8th and 10th November at New Delhi, G.V. Pant Institute. The course director is Dr. Anil Agarwal, and also by our founder president, Dr. C. Palnivelu, will be the main patron for this program. And any surgeons who are interested in HPV would advise them to join this program. It is a very well-structured program. And coming to the Smart Center, we have courses coming on hands-on laparoscopic bariatric surgery between 18th October and 19th October. And then hands-on laparoscopic hernia course, November 29th and 30th. And also hands-on basic laparoscopic surgery course between 6th and 7th of December. Interested candidates may contact our in-charge person, Syed, at the Smart Center in Chennai. Or you can even contact our Amasi secretary to facilitate this registration. Last but not the least, I would request Dr. Biswarup Bose to give the vote of thanks. And those who have missed today's CMA program can log in and check with the Amasi website. We'll have the recordings of this particular program. You can view it from next week onwards. Those who have really missed out Professor Jan Kukleta's wonderful talk can revisit this program. Over to Biswarup.
Thank you, Dr. Roshan. And first, I'd like to say that it was a wonderful interactive session with elaborate discussion on the IPOM Plus. So I thank very much Professor Kukleta, and I wish we would have more about Professor Palanivel. He is unable to attend, and Dr. Senthil, Dr. Pramod Shinde, and I'm very happy that this is the first CME program under the leadership of Dr. Kalpesh and Dr. Roshan. And thanks to Dr. Rajesh Srivastav for organizing this wonderful program, Dr. Pathani and Dr. Dilip Goyal. Thank you very much for this wonderful program.
Dr. Biswarup, I will just interrupt. Today we have more than 700 delegates who are watching this program.
Oh, that's fantastic.
That's wonderful.
700.
Yeah.
And we wish to thank our support from Merrill, because it wouldn't be possible without their support. I think we should thank them as well. Yeah.
And Rajdeep, who's the program director for our Amasi.
Thank you, Rajdeep. Thank you. Thank you so much for wonderful organizing of this same.
Pleasure.
So, fantastic, Jan.
Thank you. Yeah. Thank you and goodbye. Thanks.
Thank you, Rajesh, for being so courageous to take me on.
Thank you, sir.
Thank you.